I'm Heather Nelson, a senior manager in our life sciences and healthcare practices of Deloitte Consulting. I also have the esteemed pleasure of leading our health equity business. And today, Nate and I are going to talk about engaging priority communities in population health campaigns centered on three important themes: health equity, equity-centered design, and scalable technology. So our agenda today will really give you an example of a very unique case study, the Consumer Population Identification and Registration Service, also known as CPIR, which is a technology-enabled approach to a population health challenge embarked upon by our colleagues in New Zealand. Talk about the principles of equity-centered design and how important they are for the solution that was built. Talk about CPIR and demo that solution for you, and then talk about the underlying technology building blocks to CPIR and what allows it to scale. So before I go into the unique case study, I want to ground us in how we think of health equity. So to us, health equity is about the ability to fulfill the human potential in all aspects of health and well-being. By tackling structural racism, the structural flaws in the health system, and the drivers of health. And health equity in particular is really impacted by the economic, social, and environmental conditions beyond healthcare, the non-medical drivers of health, as well as the structures, cultures, and technologies that influence care and well-being. And so in our discussion today, Nate and I will talk about how digital platforms and technology can really address and transform existing care models and experiences to improve access, continuity of care, and connection. So in this unique example from our New Zealand colleagues, we'll describe a solution designed to deliver on the promise of digital technology, while closely examining how the drivers of health, racism, and bias impact a population writ large. And so the solution that we'll talk about, really, the intent was not to widen the digital divide. So let me paint a picture for you. A quarter of the New Zealand population is Maori, which is the indigenous population, or from the Pacific Islands. These two groups suffer poor health outcomes in New Zealand and are twice as likely to die from preventable diseases, and live 5 to 7 years less than their counterparts. This excess burden of disease is really the result of the inequities in the social determinants of health, such as poor quality and crowded housing, as well as a high prevalence of conditions that increase the risk of adverse outcomes. In particular, adverse outcomes that occur at a younger age in the Maori and Pacific population compared to other populations. And in this unique case study, we'll talk about using technology to really improve health equity and essentially talk about the challenge for Health New Zealand, which is the government entity that looks after the health of the overall population. And this unique case study is really about raising vaccination rates in priority segments of the population. And so while the disparities that I describe are local to New Zealand in this unique case study, they are truly a global representation of disparities that exist and persist across the world. And whether it's a Black woman in the United States who's 3 times more likely to die from pregnancy-related causes compared to white women, or a similar inequity elsewhere in the world, these issues really have broad implications for all organizations and businesses. And moreover, this is the primary reason that the New Zealand communities were prioritized for localized tailored communication. Tailored communication led by their communities focused on COVID-19 and flu vaccination rollout, essentially designed for and around protecting that population from getting really sick. So why we've evolved, what's important to think about is why we've evolved from human-centered design to equity-centered design that prioritizes the individual's lived experience their lived expertise, activates the community to co-design, and recognizes systems surrounding us that create experiences and insights that must be taken into account into the systems of oppression. And the reason we take that into account is because they're often the types of elements that are historically not factored into the design of solutions, and certainly not traditionally factored into human-centered design writ large. In fact, activating an equity-centered design approach in this particular unique case study meant adopting several key principles and mindsets. So centering around lived experience, that is to challenge who the expert is and have a relational conversation as part of the research process. To design with, not for, and have co-creators at the table, and situate the solution within a wider ecosystem. So the total population, just to give you a snapshot, is roughly 3 million individuals, over 70% of the New Zealand population, who were contacted via digital channels as a part of the solution. 2.5 million automated first and second booster reminders were provided, with 31% better uptake for those contacted, which is about 804,000 individuals contacted specifically for flu campaigns. So Health New Zealand, through CPIR, reached a significant portion of the population, and those campaigns included national messaging via email and SMS, as well as locally led campaigns driven by health providers across the country, so the true boots on the ground. And overall, the uptake was better as a result of the campaign in comparison to control groups who did not receive any message reminders. And so for automated COVID-19 booster vaccination reminders as the example, that improved uptake allowed for greater scale. So given this success, CPIR has been extended across other services beyond COVID-19 immunizations to flu, measles, and more recently, breast screening awareness campaigns, as pictured on the right-hand side. So the national campaigning really works for a portion of the population, but not for everyone. And so it was important to Health New Zealand to provide the tools to enable local campaigning through local health and community providers in order to support achievement of equitable outcomes for the harder-to-reach priority populations. There were over 1,200 locally led campaigns for COVID-19 and flu vaccinations, which supported the promotion and awareness of community events that were designed to truly get people along, have some fun, eat some free food, and get vaccinated. So there were over 600,000 individuals contacted as part of this campaign throughout 2022. And an example here on the right is written in the native language of the indigenous Maori population, which really translates to march to the stars, march to the moon, come along to the vaccination clinic tomorrow at Orawara Marae, which is a name for a tribal meeting house and really important to center the culturally humble experience. Hashtag protect our ancestry. How powerful is that message? When the CPIR tools were extended to flu in mid-2022, over 100,000 Maori and Pacific people were included in those campaigns, which were designed truly by the communities to ensure the message on the risk of flu and the benefit of vaccination was communicated in a way that really works for them. So again, centering around those that the solution was designed with. This resulted in 41% increase in the uptake of flu vaccinations for these communities, again, compared to those who were unable to be contacted. What's also important about this unique case study is the diversity of the team behind the solution. Fundamental to achieving the success of the CPIR program was delivering it through a team of diverse backgrounds, diverse lived experiences, diverse expertise, and technical and functional skills. And one of the hallmarks or critical success factors was strong women in leadership. The co-creation and the team you see was a partnership with the technical team, NDS, the business team, NPHS, and the local health providers, the grassroots, to deliver the solution. And another important element was truly to have the grassroots, the boots on the ground, participating as active co-designers in both the solution and tailored messaging. Important that the message was both culturally humble and nuanced to the population. So as health systems, as we zoom out of this unique case study and we talk about the broader implications for health systems, really addressing systemic bias, some of the major drivers are, one, it's the right thing to do, which we hear often, and as part of their publicly stated mission, organizations have a moral obligation to provide standardized care to all patients and to improve health outcomes. It's also good for business and society, which is to say outcomes, quality, safety, and cost. And as we address those inequities caused by racism and care delivery, we're also addressing and reducing overall healthcare costs and risks to the organization. The goal of every health system is to provide high-quality, safe care that allows people, families, and communities to live their best lives, enhance patient satisfaction, and improve the patient experience while also maintaining margins. And finally, patient trust, or as I like to think of it, rebuilding trust, where organizations realize that the existing mistrust that persists and the negative healthcare experiences among patients related to race and ethnicity exist and are working to rebuild trust and improve outcomes. In a recent study by the Deloitte Center for Health Solutions, we found that more than half of the study participants talked about a negative experience that they'd had with a healthcare provider. And the vast majority of those we talked to, nearly 80%, said there was nothing that that provider could do to regain their trust and convince them to return. Let that sink in. While some people said they would seek care elsewhere, more than a third of those that we talked to said that they would skip or avoid care altogether, which is a troubling percentage given how such a decision could really impact a serious health condition. So why add to all of this equity-centered design? In our minds, or our thoughts, is that equity-centered design is a way to narrow the digital divide and narrow the gap. And as the case study today, as I shared with you, digital technology truly can transform existing care models to improve access, continuity of care, and care management. However, to deliver on the promise of these technologies, organizations must closely examine how the drivers of health impact their populations and has the potential to lead to widening the digital divide for certain population groups. And as digital technology continues to transform care delivery, organizations must consider the key challenges that may compound existing health inequities. Things such as digital literacy, accessibility, or algorithmic bias. And so therefore, a successful digital engagement experience will meet the populations where they live, build upon and incorporate equitable access, and apply ethical technology standards that mitigate bias. So when we think of equity-centered design, what we're really talking about is moving away from a design practice that centers on the interpretation of people's needs, a design for mindset, to a practice that allows the most impacted to lead the way, a design by mindset. So let me give you 4 examples, and some of those leading examples around how we've applied equity-centered design and ways to even think about equity-centered design in your specific solution development. The first is around partnering with community organizations, which is to say, how will you incorporate constructive feedback from community organizations to make digital engagement more effective? So here's some examples, the way to sort of think about it. So when we need to learn from historically underserved or marginalized audiences and communities, we may think of conducting comprehensive ethnographic research and developing holistic insight into stakeholder attitudes, behaviors, beliefs, and values within a particular topic. We may think of, or we may need to engage communities and audiences where trust building is key to success, especially in the example I shared. And therefore, we can build community partnerships and really leverage those in the community who have the trusted voice to pave the way for more sustainable innovations. So build with. And finally, connect with the new and new to you audiences and communities to make culturally resonant impact, especially as when we are creating concepts and strategies that are unique, culturally resonant, and sustainable for various audiences, new to you and new to the world. The second is around incorporating diverse consumer perspectives into the design process. And if an algorithm isn't equity-centered, it could have the potential to automate systemic bias into the system. So I think of 4 elements in terms of leading practice examples for how to overcome that. The first is actually employing an ethical framework. That is to say, instituting ethical frameworks as a practice to guide design, development, implementation, and usage of advanced analytics such as predictive algorithms, AI, and machine learning, as Nate will talk about. And accounting for existing biases, that is to say, understand and account for existing biases in the underlying data that's then used by advanced analytics and how it's being deployed to direct interventions, particularly as we're thinking about targeted populations. And in so doing, account for the potential to exacerbate existing biases when applying these insights from analytics. And the third is really thinking through the continuous quality assurance and improvement as part of the solution design and deployment. That is to conduct third-party audits of products, implement tests of fairness, ensure transparency, and work iteratively to remove bias. And finally, think about the ongoing measurement and evaluation that's required, which is really integrating measurement of disparities into the program and into the planning process in order to rapidly identify and take action on disparities as they persist among access, engagement, experience, and/or outcomes. And there's a really remarkable example from Chicago Booth's Center for Applied Artificial Intelligence, where they've created an algorithmic bias initiative to identify and mitigate bias in commonly used healthcare algorithms. And they publish their research detailing these examples as they partner with healthcare organizations to develop those mitigation strategies. So examples do really exist in the marketplace for us to learn from and incorporate. The third is around choosing channels that reach diverse populations, and especially in the example that we shared today, utilizing a wide range of communication channels that really incorporate culturally sensitive language and culturally nuanced language. Designing intuitive and accessible user experience is really about creating solutions in simple language, straightforward design, and simplified navigation that meets the needs of customers with varying ability levels and varying language preferences and nuances. It's about dedicating and targeting support to expand care models, in this case, to include positions such as, in the case that we described, digital navigators to provide virtual or even in-person support, and design around proactive outreach, as Nate will talk about, where the strategies for customer segments, especially of higher risk populations, are taken into account to overcome some of the nuanced engagement challenges. The other is around structuring educational content and materials, where we create multimodal and multi-language training content to help not only patients and family members, but healthcare providers navigate technology solutions, including instructional documents, visual workflows, and video tutorials, just to name a few. And the other, probably more nuanced and more important, is the engagement of social support. So building digital health solutions and technology solutions that can also engage customers both horizontally and vertically along social support networks. And finally, engaging a much more representative and inclusive workforce. And as I shared in the study that was conducted, almost a third of those individuals would be willing to return to the health system if someone, a provider, looked like them, talked like them, had a similar lived experience to them. And so having the inclusive and representative workforce to engage and train a diverse and representative workforce to deliver care in a culturally competent and culturally humble way. And the fourth and final example I'll share is really around prioritizing cultural humility, which is really important for patients to receive care from clinicians who look like them, talk like them, and have shared life experiences. And this really is about leveraging local partnerships. It's about working with schools, shelters, libraries, community health centers, and more to set up connectivity zones where those without reliable access, as it were, or reliable connectivity have a way to connect to needed care. It's about customer advocacy or patient advocacy, where you're both educating and engaging with customers on existing state and federal programs in the cases of affordability, barriers, and the like, truly to support and bring a wrapped around solution to bear. And the last is around localized health hubs. So think about that in terms of connecting patients across both physical and virtual with technology and staffing resources to assist in care delivery. There's a couple interesting examples. Canopy is one of them, in terms of where they've set up a virtual multilingual platform, similar to what we shared in the Health New Zealand example. That organization is then able to partner with plans, academic institutions, and individual providers with the mission of eliminating language as a barrier over the next several years. So among these examples of how we've leveraged equity-centered design, I want to give the space and the floor to Nate to talk about the underlying technology building blocks of the CPIR solution.
Thanks, Heather.
Yeah.
Hi, everyone. My name's Nate Bechtel, and I am a healthcare leader on our communication services team here at AWS. And I'm really looking forward to talking with everybody about the AWS technology building blocks that were used in New Zealand to build the CPIR solution. But first, I just want to take a step back from the technology and look at the approach and the timeline of the solution creation. I think it's important to remember that front and center in this delivery was a notice of the importance of maintaining trust of the priority populations in New Zealand, because it would have been incredibly easy to lose that trust quickly. And you can lose it via doing really simple things wrong. Untargeted segments of users, campaigning to untargeted segments. A lack of adherence to things like do not contact lists or unsubscribe requests, excessive message volumes, and most importantly, and I think Heather mentioned this quite a bit, message content that isn't culturally nuanced and humble to the specific individual that's receiving it. But the CPIR technology was built specifically to avoid all of these downfalls, right? CPIR was built to enable locally led campaigning with the intelligence to ensure that the campaigns were respectful to the consumer and nuanced to the message that they would like to receive. The solution allows these local care teams that are ingrained in these local communities to really run the campaigns. So I'm going to talk about the AWS technology that New Zealand built, but first I want to jump into a timeline about the evolution of the solution. So the evolution of Chipper is really a story about how to iterate and adapt in the face of new challenges. It began as a solution designed to meet the challenges of a global pandemic, and it quickly adapted along the timeline to expand far beyond that single use case to, as Heather said, handle a variety of healthcare use cases that are driving better health outcomes for priority populations in New Zealand. And I think from an AWS technology perspective, as you look along this timeline, it's really a proof point of the flexibility that the AWS tool sets and building blocks provide to our customers. So a quick overview of the timeline. It's November 2020, and Pfizer releases their vaccine and says it's 90% effective. So this is the first sort of challenge for New Zealand, which was to first identify patients that needed the vaccine and tracking those who had already received it. So to do that, it required integration of data from a variety of sources. We're going to talk a little bit about that on a few slides. Once they were able to get that data into one place and get a comprehensive view of total demand for the vaccines, the focus really shifted to registering patients and building targeted engagements. So they weren't doing targeted engagements from day one, right? It was a step process that they stepped into, but Chipper eventually became this sort of enterprise data platform that built on AWS, of course, that allowed local campaign folks to campaign to the masses. Given the granularity of the data sets that were brought into the Chipper solution, they were able to then take these tools, distribute them to local healthcare providers, and give them the detailed data that they needed to execute their campaigns. This was highly personalized, tailored communications targeting their specific populations in their local communities. And in the design effort here, of course, there was a ton of effort focused on health equity. So Chipper continued to adapt and eventually started to leverage automation, machine learning, and analytics, and that's sort of where it lives today. So what does Chipper actually do today? Well, it's no longer just engaging across COVID. As Heather mentioned, it did have a 30% uptick in COVID screenings versus the control group, but today it also has increased flu vaccine uptake by 40% and mammogram screenings by 5 times. So it's in priority population, so it's really driving more equitable health outcomes. So let's take a look at how Chipper accomplished this. Chipper integrates the principle of equity-centered design to create highly personalized, multi-channel campaigns designed, of course, by local healthcare providers to target local segments. This starts with, as I mentioned before, integrating and normalizing data from a variety of sources. And you can see those sources on the left-hand side there. The data was a combination of demographic data like location, tribal affiliation, as well as health service utilization data from the NHI or the National Health Index, which acts as a system of record for an individual's healthcare interactions, including vaccinations and hospitalizations. Then, using AI and analytics, Chipper creates ad hoc campaigns and automates journeys to engage consumers in a way that reflects an understanding of their unique preferences. The final step in the journey is to use a variety of channels. As Heather mentioned, this is a key piece to disseminate information to target specific customers. So what's under the hood of Chipper? Well, let's take a look at a high-level AWS architecture and some of the solutions and technologies used to build Chipper. So, as I've mentioned a few times, there was a massive data integration and ingestion effort. We needed a way to get all the data out of the existing data sources and applications and onto S3, where we could really get a 360-degree view of not just the patient's health history, but a cultural view of that patient as well. To do this, we leverage Kinesis and AppFlow alongside API Gateway. Kinesis and AppFlow bring the data into storage on S3. And once it's there, we can use our processing and orchestration tools, Glue and Lambda, to stream and integrate that data into our activation and analytics layer. Chipper leverages Amazon QuickSight, which is our cloud-native business intelligence tool, to build dashboards that allow for a variety of use cases, but predominantly two. One is the use case we've talked about, which is enabling local health workers to design campaigns. And another is for centralized folks at the national level, like business analysts, to look at the exact effectiveness of campaigns and monitor that as campaigns are going out from local regions. The Chipper solution also uses a variety of machine learning and AI tools from AWS. Sentiment analysis and keyword recognition is being done across all the SMS and email communications coming from patients to local healthcare providers. And we do that using Amazon Comprehend and Amazon Medical Comprehend. Comprehend is our machine learning-backed NLP, or natural language processing tool, and Medical Comprehend is that tool focused on medical language. We really use that tool to monitor and review millions of emails and SMS messages in real time to understand things like sentiment and look for keywords. We then take those insights, we deliver them back to local community providers so they can provide the right care to that patient. Another use of machine learning is risk modeling that's being done. So Chipper is using machine learning tools to do risk modeling across populations to identify for things like specific patients that are at risk for hospitalization, for instance, if they get COVID. When the model determines that there's an extremely high-risk patient, it'll locate and contact their health provider and make sure they're aware so they can engage. And then on the AI side, Chipper uses SMS chatbots powered by Lex, Amazon Lex. Lex is our two-way chatbot tool, and it powers for Chipper two-way conversations with patients via SMS, text message, via a question and answer bot that allows for a variety of use cases. For example, identifying people that need a callback after they receive a message over campaign, health questionnaires, and screenings. And I think the real backbone of Chipper was the at-scale, targeted, omni-channel communications to millions of New Zealand citizens. And this was made possible by a set of solutions called Amazon Communication Developer Services. Amazon Communication Developer Services, or CDS, is a set of SDKs and APIs that developers can use to embed customer communications into their own applications or software. Developers use CDS to improve communications with their customers across a variety of use cases, everything from application to person communication, asynchronous communication, or real-time communication. And CDS supports a variety of channels, everything from SMS to email, push notifications, in-app notifications, voice, video, voice over PSTN, etc. Essentially, these services allow you to communicate at scale across any modality globally to your customers. And a core service under this CDS umbrella is one that I mentioned, and it's called Amazon Pinpoint. And Pinpoint is really a foundational tool from AWS for our customers that are looking to create targeted and tailored communications with their customers. It manages all of your communication channels of choice and allows you to intelligently choose how and when and what channels to use. It actively collects customer data from all of these communications and other sources, so you know what your customer cares about right now and where they're actively engaged and where they're not engaged. Pinpoint then gives you the ability to push things like recommendations, messaging, notifications, all based on that real-time activity of a user, making sure the communication is extremely relevant. It's an industrial-grade communication service. It's actually the same one used by Amazon.com and all of our subsidiaries worldwide for things like messaging, notification, and analytics. And the real power of Pinpoint is that it's not a one-size-fits-all solution. Today, I'm going to give you some examples of course, in healthcare and how Chipper uses Pinpoint in New Zealand to communicate with priority populations. But Pinpoint is a flexible solution that's used cross industry. So everything from media and entertainment to financial services, across the board, Pinpoint's being utilized. And it's able to deliver this flexibility via purpose-built infrastructure that integrates into existing technology investments. CRM, for instance, can plug into Pinpoint, and we can enable a CRM to do things like transactional, promotional, or mass communications. Whether it's a one-time password that allows a patient to log into a patient portal, or an SMS conversation powered by a chatbot, it can all go out over Pinpoint. And as it relates to the Chipper solution in New Zealand, there are really 4 key functionality areas that I want to discuss. One key piece is the campaigns and journeys features of Pinpoint. Customers use Pinpoint campaign logic to deliver the right message to the right person at the right time. If organizations need multi-step campaign orchestration, Journeys is a tool that allows customers to basically create complex if-then statements that allow for targeting based off of customer activities or customer-based actions. Another key element of Pinpoint that I've mentioned are the insights that come out of the tool. Did a patient read an email? Was a text message delivered? Does a patient's phone, is it even capable of receiving a text message? So in the Chipper solution, it combines the campaigns and the insights tool to create something that Chipper calls the Smart Context Details model. What this does is it incorporates all that engagement data coming out of the population health campaigns, and via Pinpoint, it creates a rule-based model to determine whether an individual responded to that campaign and if they took action. Did an end user, did a consumer receive an email that said they're up for a mammogram screening? Did they read the email? No. All right. Well, they need to read that email, so let's send them a message on a highly engaged channel. Let's send them an SMS message. All right, they got the SMS. Did they end up scheduling their appointment? Yes, they did. Fantastic. Let's shoot them another SMS 24 hours in advance to make sure that they go to their appointment. And then did they actually get the mammogram done? And this is where the clinical data comes in, right? So they did. They went in, they got the mammogram done, great. Well, clinical guidance says for this specific patient, they actually need to go and get a follow-up in a year. Let's make sure we email them in a year. So that's what Chipper's doing, and it's really the power of insights combined with campaigns in Pinpoint. A third piece of Pinpoint functionality is our segmentation. Pinpoint allows for audience segmentation using either external data sources in a static way, like all patients living in a particular geography or with a particular tribal affiliation, or dynamic segmentation. For example, let's segment all patients who have visited a healthcare provider in the past 12 months and have a specific tribal affiliation. And based on these segments you define, Pinpoint then allows for personalization. Personalization of content, right? So this content can either be static, designed by a user, or with our tight integration with our machine learning tools, it can be dynamic. This content can take the insights coming out of our machine learning tools and create content tailored for that specific user. And that's what Chipper's doing as well. An example of segmentation in our machine learning tools in the Chipper solution is Chipper's health service eligibility segmentation tools. Using analytics, machine learning, and Pinpoint segmentation capabilities, Chipper can determine what health services a customer is eligible for on their immunization, screening, or other health service data, and the communication that goes out is going to be personalized to that specific individual. So for me, that's the power of Pinpoint. It's personalized, real-time, engaging content that's so targeted that it can drive more equitable health outcomes across an entire country. Now that we've talked about Pinpoint and some of the other AWS services used to build Chipper, let's take a look at what the actual Chipper solution looks like.
Kia ora. This video will walk through the end-to-end process for planning and executing a campaign for breast screening awareness, with a focus on equity and prioritising communities with health disparities. As a health provider in the screening service, I would start by viewing the geospatial map of the country to get a view of the population and the screening uptake. Today I'd like to focus on the priority groups, which are women who are overdue for their mammogram or unscreened, and focus on Māori and Pacific. I can select this on the left-hand side of the map. The map will now update to show the screening rates for these groups within each of the regions in New Zealand. The yellow outlines show the different provider catchment areas, as there are 8 providers in New Zealand. As a provider in Counties Manukau, I can hover over my area and see that just over 4,500 women meet this criteria. They're either overdue or unscreened, and they're either Māori or Pacific ethnicities. Regions highlighted blue means that there is high screening uptake, and red means that there is low uptake in a particular region. I can focus on areas of highest need, highlighted red, for example Papakura and Pukekohe. By switching from the current population count view, which shows the heat map according to the number of individuals, I can also see the heat map by proportion or percentage of the total population, and it will adjust accordingly. I'm ready to start planning my campaign, and for this I'd like to run one in Pukekohe, as we will station a mobile screening unit with an aim to increase uptake in that region. What I'd do is I'd enter in the domicile field the areas that I want to focus on. The map will then update to show these areas, and I can hover over these to see the volume breakdown of women who are either unscreened or overdue. This is showing that there are 139 women that are either Māori or Pacific and living in these areas who are either overdue or unscreened. Now that I have an understanding of the population I'd like to focus on, I will request a campaign using the campaign request form in this same window. I'll enter in my details, which includes the organisation that I'm from and what date I'd like the campaign to be sent out. All the details I entered during the planning phase are auto-populated in this form, such as the areas I'd like to communicate to, the ethnicity of focus, the age range, and the screening status. I'll pick the channels, so both SMS and email, and then craft the message for the campaign here. I can tailor this to be specific to a local community event that's happening this coming week, or, for example, make the messaging different depending on the screening status of a woman. For example, a woman who has never been screened before may need more information about the benefits of a mammogram than someone who is overdue. This message will be signed off by my organisation, so a consumer knows who the message came from. Once I submit, I can double check that the details are all correct before sending this across to a central campaign operations team to action on my behalf. And this is what the email campaign would look like, which was sent to women in Pukekohe who are either unscreened or overdue. As a provider, I can determine the design and the imagery that will resonate with my community, like what is shown here. The key messaging is highlighted, and it's easy to understand with a clear call to action. Call us or email to book in to a clinic close to where you live. And with recent campaigns of this kind, we have seen 10% uptake, so either a booking or a mammogram for Māori and Pacific women as a result of receiving a message from a provider, compared to 2% uptake for a control group who did not receive a message. This highlights that a locally tailored message can deliver equity gains for a population.
That's a powerful story, and to see it in action, even more powerful. So really, CPIR is a blueprint. We can learn a lot from the success of CPIR and apply the lessons to other populations, as you heard us describe, and address other health challenges. The hope is that CPIR can serve the blueprint to apply AWS technology across the board to address health equity at scale. And if I don't leave you with anything, remember that healthcare is deeply personal. This is especially true for communities who may have been left out or marginalized by the traditional healthcare system. The power of CPIR is really delivering the tailored and precise healthcare messaging that you heard Nate describe. that promotes patient and provider engagement, that's using digital and cloud technology not just to reach millions of patients, but to make each patient feel that that specific communication was designed for them. So I just want to thank you for your time this afternoon and leave you with 5 things. 1, local, local, local. Localized, tailored messaging and campaigns. Designing with versus designing for. Building into our designs the ability of our solutions to truly be tailored and meet people where they are and respect the lived experiences that they bring. Doing this with a diverse team, diverse experiences, diverse talents, and diverse expertise. Intentionally mitigating bias and impact, designing for impact, implementing for impact, and measuring impact. Again, thank you so much for your time today. The challenge to achieve equitable health outcomes is in front of us. And I encourage you to be bold, be courageous, and be humble. Feel free to come up and ask questions or reach out to Nate and I via email. Thank you.